Hey everybody, it's Wednesday night, and I know you can barely tear yourself away from all the ongoing election coverage, but if you've had enough of all that fun, we'd love for you to give us a little bit of time. I'm here with Dr. Rogers, we're at work, and today we are going to be talking about something very important, that is how to lose the COVID-19 pounds that most of us have gained over this year. And Dr. Rogers is phenomenal. Board certified in internal medicine, also in bariatric medicine, and so she's got all kinds of insights for us, and is going to explain a little bit about some of the programs offered here at Dr. Rogers Centers at our Redland Road location. So thank you so much for doing this.
Thanks for having me today.
I know we work together, and so I should have learned some more about this, but I always tell the patients, like, I'm not the one, I really can't help you, you need to come and talk to Dr. Rogers, because it's a huge problem, right? Just in the country in general, and then obviously San Antonio has been unfortunate enough to be designated one of the fattest cities in the country. So we've got a lot of factors contributing, but they come to me thinking it's all going to be fixed with their hormones, and they'll feel better with their hormones being balanced and optimized and such, but it's not going to just jumpstart their metabolism, is it?
Yeah, I mean, sometimes I think people feel like, because we'll get patients that come back and they go, you know, I feel better, but I haven't lost weight. I mean, hormones, even if you balance them and you're still eating Big Macs, you're not going to lose any weight.
Exactly.
Right? So
exactly.
You're going to feel better maybe about eating the Big Mac, but you know, you're not going to have that weight loss. So it is a big part of it, and you know, we know is when women especially get into menopause or that perimenopause, they lose potentially about 20% of the metabolism.
Yeah.
You know, and we'll hear those patients say, hey, you know, I feel like I haven't changed anything.
Yes.
I feel like my hormones are, you know, upset now. You know, I'm having the hot flashes, and now I'm gaining weight. I do think those patients, probably when we put them on their hormones, you know, they do start losing the weight. But if you're having an obesity problem, which is a disease, that's how we have to treat it, then we have to look at it like a disease and treat it like a disease.
Yes.
So I think hormones play a big part of it, but it's not the answer, just replacing hormones.
I agree. And then what you said kind of gets to the kind of the crux of the matter. Everybody seems to think and realize that their metabolism does slow at some particular age, but it's not necessarily like at 45 it happens, or at 50. It can happen kind of anywhere along the spectrum, can't it?
It can happen anywhere based on, you know, illnesses or, you know,
surgeries,
hormonal
big
imbalance.
stresses.
It could be a lot of stresses. If your cortisol levels, which, you know, we can really look at all of those to see what's going on. But it's definitely, I feel like if we do get a metabolic rate, it really helps to be and enlighten you to, this is what I need to use and how many calories I can take in and out to lose weight.
Great.
But then the other part is that what happens to so many people is they, you know, we put you on a plan and you lose the weight, but how many calories do you really need to maintain your weight?
Right.
So you have to repeat the RMR once you've lost your weight to then know what are you going to maintain with. And I think that is a key for people to maintain, which nobody really does.
Exactly. People, the recidivism rate, or the rate you gain the weight back that you've lost, is so high. And really we want to help empower people, give them the tools, the information, the education that they need to make the lifestyle changes, because you're absolutely right. When we lose weight, we're going to have a new resting metabolic rate. And in a second, we're going to look at this wonderful device that we have to calculate it, because a lot of people come and talk to me about their Apple Watch, and they'll go, my Apple Watch tells me that I'm burning 2,500 calories a day. I'm talking about women who are not much bigger than me, and I'm thinking, like, unless you're Michael Phelps level swimming, you don't need 2,500 calories a day. I mean, most women, middle-aged women, I'll talk about myself in this, and the first thing I think is, my God, if I ate 2,500 calories a day, I'd gain 40 pounds.
Right. I mean, you got to think all of that is based on that Harris-Benedict equation, which was made in 1912, I think, with 25 white guys. Okay, so it's way outdated.
Yes.
And so it's just a calculation. And even if you use like MyFitnessPal or use some of these other, which are great tools.
They're cheap, dirty, right?
Journaling is great tools.
Good.
What happens is when you start putting in what you're eating, or you say, I'm going to eat 1,400 calories, and then you walk 10,000 steps, it'll actually add more calorie load on there. So you can end up gaining weight by the time you finish with one of those apps. Because you really can't. You know, one thing that we talk about, you can't add exercise as part of the weight loss
awesome
calorie deficit.
Yes.
when you start to really to lose weight. You can use it for maintenance.
Yes.
And that's what the metabolic rate we can look at and show in the clinic. So I think a lot of people get frustrated. They go, I don't feel like I'm eating this much. I feel like I'm exercising all the time.
Yes.
And they're starving,
Yes.
right? Because they're exercising at too high a level. And so therefore they quit, because it's
Yes.
like, why am I doing all this if I'm just going to gain more weight?
They get frustrated.
Absolutely.
And what is your thought about these steps before we come to the RMR? People tell me all the steps that they've taken a day, and kind of, you know, my thought is like, I'm not going to count my steps, because most of the people I know who are tracking their steps aren't losing any weight. So I don't care how many steps I take, to be very honest.
I mean, one way, you know, we could talk about it on here. One way I kind of, when we look at the metabolism, is that just as what I, you know, talk to patients, as a human, we should move 10,000 steps a day. That's
Yes.
normal.
Yes.
Being alive.
Yes.
Right?
Good for your cardiovascular
Doesn't
health.
count for
Yes.
anything except you've moved for the day.
Yes.
Now, when you walk the next 5,000 steps, now you can bring those exercise calories in for maintenance.
Interesting. So that should be your baseline.
Baseline is 10,000 steps.
Yikes.
But if we look at most people, like I would say most of my patients, when they first come to us and we're kind of talking about weight loss, probably average about 2,500 steps. So everybody's working from home.
Sure,
You only
sure.
move to the kitchen, you move to the,
To the
bathroom,
bathroom.
and then that's about it.
Yeah.
Because everybody's afraid to go outside, right?
Right.
So 2,500 steps. So you're 1/4 of what you should be to try to keep your metabolism going.
Sad.
So that's when, you know, you're really going to potentially start gaining the weight.
Sure.
And it makes it really, really hard to maintain. You
Right.
pretty much would have to eat nothing to maintain.
Right. And then what about all those kind of the common knowledge and thought processes that if I want to lose weight, 85 to 90% of that is what I eat, not what I do. You say it so all the time.
Yeah,
you can't
absolutely.
outrun your fork. You can't do it.
No, and the thing is like when you look at the metabolism and you can see when you do maybe 10,000 steps, you know, I mean, I'll look, okay. So like here, I'll just, you know, kind
Yeah.
of show you here. So this is a typical female.
Okay.
About your size, but you're much skinnier.
Shorter. Yeah.
You know, so here's a typical female, you know, in her 60s, 5'3".
I'm not quite in my 60s.
154 pounds.
Okay.
And so lifestyle and activity, what she gets to count
Yes.
calorie-wise for 10,000 steps, 125. That's one Oreo.
Yeah.
So you walk 10,000 steps, you eat the Oreo, you're back at 0.
That's very disappointing.
So,
It's disheartening if you think that that's what,
And
yeah.
so then if you walk another 5,000 steps, which is another 2 miles, you could eat another 156 calories.
Interesting.
So an Oreo and a half.
Okay, I was going to say half of an Oreo. You can eat the chocolate off of one.
So
Yeah.
it's so minimal
Right.
what you can pick up there.
Right.
And so that's why it's hard.
Right.
That's why it's hard to stay thin.
Yes.
For some people.
Yeah.
Especially if you're a mesomorph or if you're, more of an ectomorph or something.
Yeah.
It's hard because genetically you're not necessarily supposed to be thin.
Right.
You know?
So you have to struggle against your
Right.
kind of wiring and stuff.
Yes.
Fascinating. See, I've never really understood all these steps things. All I know is that most of the people that I know who are counting their steps aren't really losing. So, you know, there's other ways to go about it.
It's good for, it's good for health.
Activity,
And when
yeah.
people are, when we're trying to lose the weight, I never want to, I want people to exercise, but at the same time, we have to exercise in the correct pace for the weight loss, which is another big key. So you
Fascinating.
got to think about when you're exercising, and as soon as you start taking a deep breath, or you can't sing, or you can't talk, you are no longer burning fat. You're burning carbohydrate.
Yeah.
So these people, they go out, they work out really, really hard, and
Yep.
especially your body type's a mesomorph or an endomorph, you worked out really, really hard. Now you've done nothing but burn sugar, right? 'Cause
Yeah.
you were anaerobic, you burn sugar, so you walk out and you're like, oh my God, I'm starving.
Right.
So now you're going to go
Yes.
eat. And remember, we can only have 2 Oreos. So now you gain weight.
Yes.
And so now it's upsetting.
Plus,
right?
then, those people that are going so hard also tend to increase their cortisol levels if they're doing like CrossFit 5 days a week and stuff. It's not great metabolically to be training that hard, not taking rest days, not doing as much cardio. So,
Yeah, it
interesting.
takes a very special type of person that
Right.
wants to do something. That you're looking for a different body type.
Right.
there, you know?
Interesting.
You're more likely going to be a little bit more stocky.
Yeah.
If you're going to be doing that, whereas if you're doing more bar classes or Pilates, more elongating, more fat burn, you're going to be thinner. Typically.
Bar class is my favorite.
Yeah.
So when someone comes in and wants to do a weight loss program here, it's really cool because there's some changes to the weight loss program, aren't there?
Yes.
And it's a ton of accountability, and they get something called a resting metabolic rate calculated, which really everybody should have done. Can you tell me a little bit about how the machine works?
So basically, we hook you up to the machine, and you're basically going to breathe for about 15 to 20 minutes, very comfortable. We want you to be fasting. So imagine what a resting metabolic rate is basically, I tell patients, it's basically we're going to imagine you just rolled out of bed and you laid there. How many calories would you burn?
Your body would.
So, if we take like this patient, for instance, so she comes in, she's 62, her resting metabolic rate is 1,253 calories.
Okay.
That's what we can utilize for weight loss. So she goes on a 1,200 calorie diet, she's not going to lose anything.
Nope.
That is her maintenance.
Yep. Perfect. That makes perfect sense. Right.
So the only way we're going to be able to lose weight is to really induce ketosis.
Good.
So therefore, now we're going to override her metabolism, make her body burn 100% fat.
Awesome.
So now we can lose the weight. Because if we look at with our machine, we could see she does pretty good. So this is somebody that comes in that's probably eating pretty good because what her metabolism tells me, she's burning about 22.8% carbs and about 77.2% fat. But in order for me to have her lose the weight, I got to get her to 100% fat burn.
Wow.
So we repeat that metabolism, and then it'll show we're burning 100% fat. Hey, we're losing weight now.
So you would do this periodically as patients are along their weight loss
going
journey.
Through the line, yeah, we can see exactly what's going on there.
So the people who maybe come in and say that all they eat is boiled chicken and some lettuce without any dressing a day, this machine will tell us if that's an accurate reflection.
It does give me a little bit of a viewpoint about if that's truly happening, which we do have some women that do that.
Yeah, we do.
And now with, a lot of people are even moving. So you have, let's say that's a perfect patient. I can think of one that you sent me. I remember she was from Austin.
Yeah.
She was crying. She's working out all the time, and she's eating like boiled chicken.
It's depressing. Right.
So then she thought, okay, all I'm eating is boiled chicken and green beans. And then she goes, you know what? Now I'm going to intermittent fast and only eat that. So there's another thing to our metabolism, which is the thermogenic effect of food.
Interesting.
Right? So what's happening is that I'm seeing kind of as the new trend. So now we have women not eating very much, right?
Right.
And so now they're going to wait a long time in intermittent fast, which we know. And, we've done some research with our head dietitian, Nicole Berry, who is amazing.
Yeah.
And we have found that when women typically intermittent fast longer than 11 to 12 hours, we feel like it's starting to affect the hormones, right?
Yep.
We're starting to stress the body more.
Yep,
so
cortisol.
the cortisol goes up. Also, what's happening too, that we're kind of getting an abnormal cortisol level, is that now we've intermittent fasted. They cut out their calories. Now what have they done too? They've lowered their metabolism because now we've stopped that thermogenic effect of food because they're not eating.
Because they're not eating anything. Mm-hmm.
So that's going to be another factor that's going to drive their metabolism down. Cortisol goes up, metabolism down. They're not getting any,
they're not producing their sex steroid hormones. Yes.
Right, we're not getting anything with the therapeutic effect, of eating. Metabolism's going down. So basically, they're just slowly decreasing until they get to where they can't eat anything.
So, and it's frustrating because this makes sense to me, right? That maybe, and I don't think people are lying if they tell me stuff. I mean, some people aren't completely honest, but they'll say that, and most doctors will immediately go like, "You can't be telling me the truth," but it is possible for people to actually be kind of shooting themselves in the foot, metaphorically speaking.
Who are trying so hard,
yes,
and literally starving themselves.
Yes.
And I have to admit, there's been a few patients that have come in, and their metabolism is so low that we have them eat and to try to help bring their metabolism up, change a little bit of their macronutrients, what they're eating, but we have to bring their metabolism up so we can create a deficit so they can even lose.
Interesting. Is it a specific diet? You don't tell them like just go and hit the Chewy's buffet or the whatever?
No, we specifically bring up, the fats because we want to get their body to liking to burning fat again.
Okay.
And so we want to bring up, so we're going to do a much more kind of a medium protein, higher fat diet in that instance to try to bring that metabolism back up.
Does it take a long time of increasing or feeding them more fats to?
It's going to take 2 to 3 months to bring their metabolism back up.
Yeah, that's tough.
But it's not, you're not necessarily gaining weight.
Okay.
You're just changing that macronutrients of what's going on.
Cool.
Because when you think about losing weight, I mean, anybody, you know, you go to these programs and you're going to, you know, they put you on a 500 calorie diet. Well, anybody can lose weight on 500 calories.
Yeah.
I mean, that's as cookie cutter as you can get.
You
right?
starve yourself.
There's no brain
thought,
brain cell used in that diet.
Okay.
So, but if you think about it, when you've got to transition to maintain, if you go from 500, now you start eating at
1,800.
1,800. Now you're eating 3 times, and that's when people go, "Oh my God, I got on this diet, I lost 35 pounds, and then I did 3 times more, Dr. Rogers. I am so afraid to be ketotic." You weren't ketotic. You were just put on a bad diet.
Yeah. Okay.
You want to lose weight at the highest calorie level you can lose.
Yes. So you can maintain.
You can maintain it. You know, so that's really the key, and that's why it's so important to not use the cookie cutter.
Okay.
Because everybody that comes in, we have people that want to be vegetarian.
Yes.
We have people that want to do intermittent fasting to a degree.
Yes.
We have people that get hungry in the morning.
Yeah.
Well, you can't put them on an intermittent fasting diet.
They can't eat till noon or whatever. Yeah.
Yeah, because biologically,
Then you're hangry.
as soon as they're not on their diet, they're eating in the morning.
Oh yeah.
Right?
Yep.
So that's what we have to talk about, and that's why we're successful, because I'm going to listen to what you do, and I tell all patients the best diet's the one you do.
Yes.
I can give you a diet all day long, but if you don't ever do it, it's not going to
Just
matter.
like exercise. The best exercise is the one that you enjoy doing, so you'll do it.
Absolutely.
Right?
Yes.
That is awesome. So I hadn't even thought about it in those terms for patients, but no, it makes perfect sense why they all have so much trouble and how to help them. But then the accountability factor, because so many patients will go see somebody and they'll just get a prescription for a little crutch, right, an appetite suppressant or something, and we'll do that for patients here. That's part of it. We want to help you. But you have to get the education from the nutritionists. You have to understand what's going on in your body, because it seems like we can all read like the cliff notes of intermittent fasting and the cliff notes of ketotic diets and the cliff notes of all these things that are supposed to help, and then you don't really understand the science and you're not really doing it properly, and so you're incorporating all these weird things into your body that aren't helping you. And so you just
get frustrated,
you just
and then
get
you give up, and then you start eating again.
Exactly.
You're frustrated.
Exactly.
And then, not even, I think about a patient too. I mean, the other big thing we have is, diabetes here.
Oh, yeah.
Right? So how many times have you seen, I mean, we had a patient the other day. I mean, he's a great guy, and he just felt hopeless. He's on 80 units of long-term, long-acting insulin twice a day. So he's already 160 there, right? Then he's on, with every meal, he's taking short-acting insulin with every meal, sticking himself 4 times a day. So I think, what was that, 80 is 160, and then let's say he's on 200 units of insulin a day.
Yeah.
4 other diabetic medications.
Yeah.
Right? And his blood sugar is over 300. His hemoglobin A1C was 11.6.
No.
And he's like, "Doctor, what am I going to do?" I'm like, there's not any more medicines to put you on because you're so insulin resistant. I said, the only way we can help you, the only way is that you've got to lose weight.
Yeah.
And I can say I saw him back yesterday or today. We're 5 weeks. He's lost 19 pounds.
Fantastic.
He doesn't take any insulin with any of his meals.
Wow.
Now, and he's on 40 units twice a day.
God.
He got a little hypoglycemic, so I already have had to back him down to 35 twice a day, and then put him on half of the other medication.
Right. That's
5
amazing.
Weeks. 5 weeks.
Yes.
Right? So, and that's what I say. You're exercising and what you eat is much more powerful than any medication. Because we think about diabetes medicine. Every diabetic medicine lowers you 1 point on your hemoglobin A1C. So if your hemoglobin C is 11, to get to 6, you're going to have to take 5 medicines.
That's so depressing. And then, but you're making impactful changes. Like as doctors, we know, like to get the diabetes and the hemoglobin A1C, you are doing so much to help every single thing about this person's well-being, his mental health, his cardiovascular health, his bone health, everything. And then he feels better about himself too, because he's losing weight, he looks better, he has more energy, he probably sleeps better. Everything is related, right? It's not just the hormones. I know people come in all the time and want more and more hormones, and you're like, Think of wellness as a pie. Hormones might be 15% for you and 30% for you, but you have got to optimize your weight. You've got to be able to sleep well through the night, manage your stress, and move. And that is like the foundation for wellness, then supplements and other things on top of it. But the weight loss is what most of us are struggling with. I mean, I see these statistics where they say like we're on track to be 50 or 75% obese or overweight in the next 20 or 30 years with the way that we're eating and gaining weight. And that's really a frightening statistic, because obesity is directly increased risks, obviously, for heart attacks and heart disease, for strokes, for diabetes, for dementia, for high blood pressure, cancer, all of it.
The only thing that's good when you're heavy is your bones.
Yeah, because they have to work harder. Because there's more stress on them. Yes.
It's not good.
Yeah.
And I think hormonally for us too, you know, when we see patients, you know, we have to think about females, you know, is that when a female is obese, I think it, and you probably know better, it's like a 400% increased risk of breast cancer.
It's a huge increase.
Because your fat has that aromatase enzyme that's taking your hormones and making more estrogen and actually making the bad one.
The bad estrogens,
and
yeah.
So then you want to be on more hormones to feel better, and your body is already producing these. But a lot of times why you feel so bad is because we have that estrogen dominance.
Yeah.
And so, you know, it's trying to balance that. Whereas if we could lose that weight, get rid of that fat, your estrogen comes down.
Yes.
And think about how many we see that you can almost, when they come in, you know, and they're overweight, you know, and they'll say, you know, I had bleeding issues. Did you have fibroids? Do you have endometriosis? Of course, because you've been estrogen dominant your whole, you know, your whole life. And I would attribute, you know, with Dr. Askew, because I learn every day from her about hormones. You know, there's so many times that with these patients, we need to try to get them and try to help them with the hormones, but because those estrogen levels are so high, then we, you know, we run into the endometriosis, we run into the fibroids and all these things. And then we see they come from other doctors, and the only thing that a postmenopausal woman is on is estradiol.
Yeah, oral estrogen pills.
So now in the menopause part, we've made them estrogen dominant.
Again, exactly.
And you kind of just scratch your head on, why are we making you estrogen dominant? And the reason why you had your hysterectomy in the first place is because you were estrogen dominant. Because you were estrogen dominant.
Yeah.
And so then we make them estrogen dominant again. So it's, you know, I think that's about the balancing part that we actually try to do here.
Right.
With, you know, you have an expert here with hormones, and then I can get the weight loss so that we get everything in balance, not only with hormones, but just through what you're eating and what you're doing.
Wellness. And I love it that we're here together so that we can collaborate, and I can come and ask you questions like I do all the time about patients, you know, with their internal medicine, their heart issues, their joint issues, their rheumatologic issues. And so it's just great that we can communicate with each other. So we have kind of, you know, it's not totally one-stop shopping, but tons of services for patients outside of just their great primary care, their hormonal health, their wellness. We've got fun services like the sexual enhancements and stuff. We've got a bunch of foods for patients that are on the weight loss programs. So you can get your healthy foods that have been selected to optimize and match the plans that you're on to help with your journey here at the office. We've got the supplements that will hopefully help to stimulate your mitochondria and your metabolic rate and all of these things. And then we've got our spa services for once we've lost weight and then we want to, you know, do other things. Tighten up the skin and all of those things. So it's a lot of fun, and we offer a ton of services, and we do see a lot of patients who've done attempted weight loss at other places, and then they come because they couldn't maintain it. And so hopefully we're giving them the tools not only to lose the weight, but then to maintain it. And I think appetite suppressants are important. And so the visit with the doctor, if you need a little crutch, like if I get hangry during the day and I need something to take the edge off of it, there's tons of, not tons, but there's more than a few options for appetite suppressants and things to kind of help people curb their appetite while they're restricting their diet.
Yeah, and you know, and you want the appetite suppressants to match the patient also. It's, you know, everybody thinks phentermine, I think, first and foremost, but a lot of people don't tolerate phentermine. A lot of people don't like phentermine. So we have different, you know, we have different options we can use. And I know you had talked about, you know, Ozempic is a
my
great
favorite.
one, or what we call the GLPs. I think
Yeah.
they're a amazing medication. So anybody we can get on those, we
Yeah.
will definitely use.
That was my
You know?
secret weapon that helped me
Yeah.
lose the COVID weight earlier in the summer. That Ozempic, I didn't know, and then I was talking to someone here, and they mentioned it, and it worked great. You know, I'm not diabetic or anything. It didn't drop my blood sugars, but I mean, I had no cravings.
Yeah,
you
it
know,
stops your cravings. It makes
filled
you
up
think
faster.
You're, you know,
Yeah.
you know, it stops that gastric emptying, so you can only eat
Yes.
about
You're
half
full.
of what you know normally would eat.
Yep.
It really stops that glucagon system. We
Yeah.
don't really have another medication that really works to
Yeah.
do that so well, and it's only once a week shot.
Right.
You know, I mean, it's really pretty easy. So yes,
Yeah.
anytime I can find that insurance is going to cover
Exactly.
it, I utilize those.
Oh yeah, if it doesn't, it's ridiculous. But the other
Yeah.
one that I like is the Vyvanse, right? Like sometimes I'll take my daughter's Vyvanse for her ADD because it makes me happy. Like I'm not hungry for a little while,
Yeah.
and it's a kind of
Yeah,
hits
and-
dopamine.
And Vyvanse is great in that, you know, it works especially for binge eating disorder.
Yeah.
You know, which a lot of
I guess
people
that's why
have. And,
I like it.
And, you know, and patients can't explain it. They're just like, you know, my cravings are better. We're doing better. And naloxone, naltrexone.
Yeah, the naltrexone.
And those and Topamax, you know, we
Yes.
kind of manipulate those medications. We can have them compounded based on, you know, what you feel. So there's a lot of new, you know, drugs out
Options.
there. Yeah, and I mean, it was really, I saw in the, one of the journals is that why aren't we using more, you know, appetite suppressants? And I think they had such a bad stigma.
Yeah.
But really, nothing has ever panned out. And
Yeah.
once they had Qsymia and it showed that phentermine was good for 5 years, I think that lent to being a little bit more careful. I mean, you know, prescribing it more.
Right.
And you can do it in different doses. So.
And I like that. I think our providers are maybe a little bit more knowledgeable than some who aren't specialized in weight loss about why, you know, why phentermine might be better for someone as opposed to Ozempic better for somebody else. You know, and it's not just everybody who walks in the door gets put on, you know, phentermine.
Cookie cutter diet, and
Right.
phentermine.
Right.
You know,
Exactly.
kind of the no-brainer.
Yeah.
And you know, and some people have success there, but it's hard to transition, and I think you just end up in trouble because it's really not.
Yeah.
It's really not meant, you know, meant
Right.
for you. And you know, and now we're really trying to open up, and you know, we can do, you know, with our virtual abilities
Yeah.
now.
Telemedicine's been nice.
So, you know, we can do virtual weight loss really anywhere in Texas.
Great.
So we're excited, you know, to offer. We have all of our products and everything online.
And they can
now.
order online. For the people
Yeah.
that are, you know, high risk and really need to still quarantine and isolate, you can order online and get your products shipped to you and then do your visits with the provider.
We do the providers
Yeah.
and ship your shots to you. So we have all of that. So we're really trying to reach out to help everybody in the,
I love
you
it.
know, in the state
Yeah.
of Texas. Dr. Askew here can do
Yeah,
your
we can do your hormones
all
over the
The
phone.
state of,
Exactly.
Texas, and just drive in the one time, and we can give you your.
You got to come in for your
pellets.
pellet.
Yeah,
Exactly.
You can do your
But
pellet.
otherwise, we've got you.
Yeah.
Yeah.
So we really are. I feel like we're, you know, branching out and trying to reach more people that want
Great.
us, or you know, it's, you know, hard driving in to create that accountability. Now we,
Sure.
you know, through technology, we can really do that
Yeah.
online now. So
And I think we've got a couple of like ancillary tests that I don't think are for everybody, right? Like everybody always thinks it's there, like a food sensitivity or a nutrient depletion. I kind of find those tests are fascinating and wonderful from a functional medicine standpoint, but that's probably not the reason why you're having trouble losing weight. So if patients want them, you can have them. Insurance may cover them partially, but it's not it's not the answer. Really, a more comprehensive look at what you've been doing and what your metabolism is, and then some guidance and expert, you know, and then accountability that you can get here with our weight loss programs is really going to be the key to helping you lose weight and then maintain it and then adapt these healthy lifestyle choices into your the rest of your life so that you can optimize your health long term and decrease your risks of all those health issues.
Absolutely.
Yeah.
Absolutely. You know,
Perfect.
And that's what we want to do here.
Absolutely. So thank you for tuning in. If you have gained the COVID-19 or any portion thereof, give us a call because we really can help you to lose the excess weight, get back to feeling and looking your best, and especially now with the holidays coming up ahead when the cookies and the tamales and everything will be coming out. So give us a call. We can help you. And thanks so much for tuning in, everybody. Thank you so much.
Yeah.